Welcome everybody to today's episode of the Great Birth Rebellion podcast, where we grapple with current research and historical knowledge to help you get the best out of your pregnancy, birth and postpartum journey. My name is Dr. Melanie Jackson at Melanie the Midwife. I'm a clinical and research midwife with my PhD, which is why I send out a weekly email which contains the resources that we use to create every single Great Birth Rebellion episode. You can join the podcast mailing list at melaниethemidwife.com. Our Great Birth Rebellion premium members also get access to podcast transcripts, additional resources, the Ask Mel a Question button, and an exclusive monthly Ask Me Anything episode where I answer listener questions. That said, let's get into it. In the interest of keeping this podcast free to you, the listener, I would like to thank our sponsor, the Born at Home documentary film. I've seen this film twice, and both times I was reminded of the joy and bliss that birth can bring. The film follows families as they plan their home births, and we get to witness the birth of their babies. And my favourite part, we get to witness the moments after when women realise that they've done it. And what stands out in this film is that birth has the power to be joyful and healing, and that women and midwives are capable of managing birth together at home most of the time. There are lots of ways to experience a joyful birth, and giving birth at home is one of them. To watch the film, head to the Demand Films website, that's au.demand.film, and search for a screening near you. If you can't find one close by to you, you can actually request a screening through the website for yourself and your local community at no cost by simply clicking on the Request a Screening button. Cinema screenings will continue through this year, 2024, and then the documentary will be available for online streaming in early 2025. So check out the Born at Home website, bornathomefilm.com.au, for more information. The team have also generously provided a discount code for podcast listeners. So enter the code REBEL10, REBEL 10, at the cart to claim your discount. All the details are in the show notes, and I would encourage everyone to get along and see this film, Born at Home. Welcome everybody to today's episode of the Great Birth Rebellion. I'm your host, Dr. Melanie Jackson, and today I have a very special guest. If you've been listening to the podcast for a long time, you'll know who she is. Her name is Ashlee Anslow from the Birthing Tree Midwifery, and she is my work wife, which means we work together with most of the births that we go to. And this episode was inspired by questions that I got from listeners, actually. Somebody asked me, can you do an episode on what midwives do at home in circumstances of emergencies? And I thought Ashlee would be a great person to join me for this one because she's the one I'm usually managing emergencies with at home. So today's episode is not specifically looking at the stats for the safety of home birth because I did cover these in episode 8. And while I have plans to revisit that research, it's not for today. If home birth is of interest to you, I would suggest listening to episode 8, which is called Giving Birth at Home. Episode 54, which I also did with Ashlee, is what midwives do at a home birth. And episode 55 is supplies to gather for home birth. So today we're specifically looking at how midwives manage emergencies at home. And we'll be using some real life circumstances that we've been in together, Ashlee and I, to give you insight into what we do and how we're prepared for them. And the emergencies that we'll be covering today are sort of signs of fetal distress during labour, shoulder dystocia, cord compression and prolapse, neonatal resuscitation, retained placenta, and postpartum haemorrhage. So, welcome, Ashlee.
Thanks for having me.
You're welcome. Let's do it. So, I'll start this discussion I just want to make 5 very quick points. Emergencies don't happen very often in a home birth, and when they do, we're either anticipating a complication and we're prepared, and we've actually transferred before it becomes an emergency. Secondly, when you're a home birth midwife, you're the one doing the antenatal care. And so a lot of our antenatal care is about helping women stay well during their pregnancy and preventing or reducing the likelihood of emergencies. And we also very carefully screen which clients we feel like we're the best midwife for and which need other help that we can't always offer them. And on the occasion that emergencies do happen quickly or unexpectedly, we're prepared with equipment. And as we have our discussion today, you'll see what kind of equipment we're prepared with. And then also we'll discuss our transfer planning strategies, because obviously if there's an emergency, we may need to transfer in. So all of that's going to be part of this episode. And we're going to kick that off right now. So
let's do it.
Let's do it. Great. Let's talk about, we had a recent client who was giving birth, and Ashlee was already there. She was the main midwife for this client. And she went on out to the birth, and pretty quickly after getting to the birth realised that she needed me to be there too, because here in Australia, where Ashlee and I are, you have to have 2 midwives at a home birth, and it's kind of nice anyway. If everything's going well, you don't really need a midwife. If things aren't going well, you need 2. So this particular situation, we arrived and everything was going pretty well, but the woman was pushing for longer than we both kind of thought she would, because it wasn't her first baby. And then about an hour after starting to push, we noticed some changes in the baby's heart rate, because midwives carry Dopplers to be able to hear the baby's heart rate.
I mean, I don't think either of us were particularly worried, given that it was a normal physiological labour. We were clearly in the expulsive stage of labour. We're not too worried about meconium at home, because obviously there's times where it's appropriate, but then there's times where it's not appropriate. So, we just had a listen to Bub's heartbeat, and it was a little bit low, which in itself, it's so common as the baby descends through the pelvis, and particularly if you've got a baby, say, rotating on the perineum from a posterior position around to an anterior position. A lot of the time, like as the head descends and that anterior shoulder comes around, their heart rate will drop with that.
Yes, and we knew that she was fully dilated, because when she was pushing and then the heart rate started to change and her waters broke and it was meconium, we thought, okay, if she's fully dilated, then this all feels like it's going to be okay. But if she's not fully dilated, then it could be a different story.
Got there was membranes on view. When there's membranes on view, the membranes are holding the cervix open. So you're kind of assuming that the head is somewhere behind there. And sometimes it's actually quite far back. So sometimes it can be a little bit confusing when you see membranes coming out, and sometimes you might think that's the head. So I think in this one, when I first got there and saw membranes on view, I immediately called Mel to the birth thinking that it was head. But, when the room is dimly lit and all oxytocin filled, we're not exactly doing things that aid our ability to tell the difference between whether it's head or waters.
Doesn't really matter at that point.
Well, at that point, I knew I need my second midwife to attend, because that's what we routinely did, and that was an appropriate call to make. And throughout all of that period of time, baby's heart rate was fine. So it was only after the waters broke that we started getting a little bit of concern for the baby's heartbeat. And there was a very small amount of head on view, which for someone who has birthed vaginally means that you're going to be having a baby quite soon.
Mm-hmm.
But there's a lot of variation in that.
Yeah. And so she was pushing physiologically, we weren't giving her instruction on that. And it was sort of going on. And then that paired with the meconium when the waters broke, and then the fact that the baby's heart rate, like you said, it wasn't terribly low, but it was lower than the normal parameters. And if the baby was being born, we were like, yep, this is pretty much what happens. But the baby wasn't being born in the speed that we had kind of hoped. And so I guess what we're trying to build here is a picture of the fact that we're actually all clinically assessing this picture. We're going, right, she's had a baby before. There's some meconium in the waters. The heart rate is changing. She's putting in great effort, but the baby isn't coming yet. What did we suspect was going on at that point?
Well, I think we both were wondering if there was some form of rotation going on, which is the most common sort of thing in that position. But the first thing that we did was asking the woman to get out of the pool.
Mm-hmm.
Obviously, women can choose how and when they give birth and what. But if you're concerned about a baby being a little bit compromised, those protective mechanisms for when a baby is born underwater can sometimes also be compromised. So you might have a baby that's more likely to gasp before that dive reflex really takes over. So, yeah, that's probably one example of a time that you may be not so keen to have the baby coming out in the pool.
And we had a chat, so we firstly got her out of the pool into a deep squat because sometimes a deep squat can help the baby, it can create more room in the pelvis. And I thought maybe there was a hand up coming with the head, and that adds more baby to the pelvis. And I thought maybe that's what was slowing it down.
There's something about that shoulder there, if they've got like their hands up and stuff, and just that turn within the pelvis.
Yeah. So we thought, okay, if it's positional, then if we create some more room in the woman's pelvis, maybe that'll create an opportunity for the baby to rotate. After we tried the deep squat and didn't really see much change, we made a decision to call an ambulance. And it wasn't that we were going to take her to hospital, because at that point, when there's that much of the baby's head on view, it doesn't seem safer to be giving birth in an ambulance.
No, and to give context, at this period of time, we weren't in the most convenient location, and it was also raining incredibly heavily, which were two other sort of situations that play into your head. This isn't like, we'll just jump in a car and go across the road. This was, you're trying to think forward and go anticipate, okay, so what if I have a baby that isn't born in great condition in response to this?
Yeah, and so that's what our thinking was. We weren't thinking this birth needs to happen in hospital. We were thinking this birth is about to happen, and the baby's giving us a few indications that it might not be coping with this part of labour. Well, this is where I guess we were thinking worst case scenario. It wasn't definitely going to happen, but we thought if the worst case scenario happens, we want to have an ambulance team here who can quickly get us to hospital.
Yeah. Right. And it also means extra pair of hands.
Yes.
Like there are some things that ambulances are great for and some things that aren't really part of their scope of practice, but resuscitation and transfer for an emergency, definitely what you want them for.
Yeah, and if you tell them it's a woman in labour and her baby's about to be born and we're concerned for its well-being, then often they send quite a skilled paramedic. And so then my job as the second midwife was, once Ashlee and I kind of had eyes at each other and I said, look, I think we should call an ambulance, and Ashlee's like, yeah, I think we should. I went and did that, and then
which had the transfer plan with like all of the address and the nearest cross street and all of that information that you need for one of those phone calls.
Yeah. So I did that while Ashlee was giving clinical care to the woman. So we're still listening to the baby's heartbeat, still watching for progress and helping the woman and doing all that kind of stuff. And so she didn't have a gap in clinical care, and I had the ambulance there as a precaution. So that was our plan that day, because we knew that we couldn't really – the baby was about to be born. We didn't want it to be born in an ambulance, but we knew we might have needed help. So the other thing we could have done, Ash, if the baby did get in poorer condition at that point, an episiotomy would have been appropriate with how much head was on view.
Yeah. Yep.
And you can listen to the episiotomy episode. So then you ducked into the bathroom with the woman.
I was trying to get her into a place where she could relax her pelvic floor and go with those urges, because when you ask someone to get out of the pool, it does interfere to a certain extent with the headspace that they're in. They're aware that you're paying attention to something, and sometimes that can cause them to basically hold on to their baby. And so trying to get her into a place where she could, birth her baby and get and the toilet seat is just so amazing for that. Like a little bit of head there to being born in the space of 1 to 2 contractions, which is often what happens with people who have birthed before. And I do think in the end that there was just the baby was rotating, but it was just the baby's heart rate was just not recovering well enough for a longer period of time than you tend to feel comfortable with. Meanwhile, I've got all my resuscitation gear and everything ready, including my suction and everything like that we carry, which you're only going to use with a baby with meconium if they make 0 respiratory effort. We do not suction other than that.
I guess the equipment we used, we got her out of the pool, we changed her positions, we were using the Doppler, we had the option of an episiotomy, we moved her into a private space because once we got her out of the pool, I think we did, we tried our very best to kind of not spook her, but, women know things are happening. So we did notice that her contractions had slowed down a little bit, which was partly we're like, right, privacy, put her somewhere safe, which the bathroom was a good place too. So we had the oxygen ready, suction ready only as an absolute last resort, and we had an ambulance on the way, and we were still listening with the Doppler. So all of that.
And there was that made us so worried that we felt like we needed to escalate things further. It wasn't like we were, doing we need to run somewhere right now. It was just
it was a precaution, and that it was a bit more remote and it wasn't the easiest location to get to, and it was pouring rain, so it would have been very hard for us to do any kind of transfer on our own, which wouldn't have been appropriate anyway. It made the most sense to manage it that way. And then the baby was born on the toilet as the ambulance was arriving, and
naturally.
It was in great condition. The baby was in great condition. But what we did notice was a big, what we call caput on the left side of the baby's head. Yeah, which meant that the baby's head was tilted in an unusual way, which is what was making it hard for it to come down and out. And those heart rate changes and probably the meconium was a result of the baby rotating in order to get into the right position to be born.
Which they do, because they're quite clever most of the time at actually figuring these things out.
Yes, but we didn't know that ahead of time, right?
Well, no, and it always is that, as part of having us at birth, it is to manage medical complexities when they arise. That's our job.
Yeah, and as Ashlee said, we have in our notes, we have this sheet in the notes that is a transfer sheet, and it's got the answers to all the questions that an ambulance would ask. What's the address, the woman's date of birth, what's her full name, what's the closest cross street. We do all this transfer planning ahead of time so that when or if we're on the phone to an ambulance, we're not flapping around the notes looking for all the information. It's all there. We're really clear and succinct, and we make sure to tell them, we don't need to stay on the phone with you. We can manage this. Just send the people.
And in this case, the woman wasn't really aware of their existence until afterwards.
Well, yeah, they didn't enter her birth space, and that was part of our role, was to keep them. They stayed out on the veranda.
Yep.
And I said, just wait there until the placenta's born. So the woman never interacted with the ambulance, and they actually never saw them.
I did some vital signs for them to be able to document, and
yeah.
And that's part of keeping obviously there's times that it's appropriate for the ambulance to come into the birth space, but to make it the least like a viewing room and something that's really going to interfere with all of those hormones that are so protective at that time, and it, actually going to stop your other emergencies like bleeding and stuff like that happening.
Yeah. And so in that scenario, and we didn't cut the cord when the baby was born, it stayed attached to the placenta because that's the best resuscitation equipment that we've got as well. And so I guess what I want to highlight with this story is that, yes, sometimes unexpected things happen, like a change in the baby's heart rate, but we've got the capacity to listen to that. And we have plans for what to do if certain scenarios are unfolding. And so that was one of them. Change in fetal heart rate, change in the colour of the waters. And then it becomes obvious after the fact, like, oh, that's what happened. We could see that there was caput and the baby wasn't positioned properly and it was just doing its thing at the last minute to rotate.
And labour is a storybook. I don't know how many times I kind of keep alluding to that with people, but it really is a storybook. And there's multiple different layers that contribute to the story that you're reading. That is what, gives us experience over time, is watching that story unfold and unfold and unfold and seeing all of the different variables.
Yeah. Yeah, totally. So that's what we would do in the situation of heart rate changes. And I have had clients before, very occasionally, where we've noticed a change in the heart rate that didn't make sense. And then when we've done a vaginal exam, discovered that she's actually not fully dilated, and in which case you don't stay at home when the heart rate is unusual, when you know that there's a lot more labour to go. So in those circumstances, we could and would transfer. Yeah, well, and also we're asking ourselves as midwives, when we're looking at a client, we're asking, is the woman okay and is the baby okay? And if there's any signs that either are not okay, then home birth is not the right place, not the right thing to continue with. We stay at home when we are confident that everyone's going to be well.
And vice versa, time limits don't apply. If you can say the mother is well and the baby is well, stop obsessing about time.
Exactly. So we're assessing every single woman and baby on an individual basis, not based on, timing. It's all about their well-being. So if we can answer those two questions as yes, the woman is well, yes, the baby is well, we've got no reason to transfer. But if we start asking questions we don't know, then we start to go, okay, well, this is where we have to make some decisions and talk to the woman about what she would like to do next, because we can no longer feel certain that the woman and the baby are well.
So to kind of allude to emergencies that we were kind of saying before, more slowly evolving with the change in the fetal heart rate pattern, I'm thinking of a client of yours that did actually go on to experience a uterine rupture.
Yes, correct.
So in that one, the initial reason to transfer was the baby's heartbeat as being the flag.
Correct. And because her previous history was that she had a cesarean section, and then she wanted to have a vaginal birth at home, which Ashlee and I do. We support women to have VBACs at home. And so when you're supporting women to have a VBAC at home, then there's certain signs. If there's a uterine rupture happening, there's usually, very occasionally, there's no signs at all, and it happens and it can be catastrophic. But most of the time it's a slow situation and you can pick up different signs and symptoms. So for her, I'd been with her for a number of hours. The heart rate was normal and fine. And then all of a sudden it wasn't normal and fine. It was elevated. And I thought, well, that's strange. If it doesn't come down, we're in a situation we've got abnormal heart rate, and that's the first sign of uterine rupture.
And so uterine rupture has become a little bit of a topic of interest for me. So it's something that I have scoured the literature for quite extensively at this point.
Because Ashlee's in the middle of a research project on uterine rupture. So she's, yes.
Well, one of the issues is there's not a huge amount of information about, my perspective is going to be women's experience of it. But someone actually recently made a comment to me like, if you have a uterine rupture, you die. And it's like, well, no. And of the uterine ruptures that I am aware of, which are mainly through midwifery colleagues or hospital networks that I know, all of the women have actually been in hospital at the time that they've had a uterine rupture, and all of the ones that were planned home births have actually transferred, often on average around 12 hours before that event has actually taken them into theatres. Yeah, it kind of paints that picture of there's a story, you're kind of trying to see how that labour is, unravelling the story in front of you, and you're following what that baby's telling you.
Yeah, and so when you're sitting at home with a woman who's having a VBAC and the fetal heart rate changes, you go, okay, this is a potential sign of uterine rupture. We're not going to wait for the other signs. We're going to hospital, which is what we did. And she laboured for another 10 or 12 hours or so there until actually other signs did develop. And we knew it was time for another cesarean section. And the woman as well knew herself that it was time for another cesarean section. It became obvious at that point. And so that was a slow circumstance. Very occasionally these ruptures can happen quickly. But again, we had the tools and the skill and the knowledge to know when is the woman okay? Is the baby okay? And in that circumstance, the baby wasn't. I knew she was having a VBAC, and I knew that change in fetal heart rate was potentially a first sign of uterine rupture. So low tolerance in that circumstance, and we transferred to hospital.
And, you're talking about with this stuff with the women antenatally as well. We know that we're only staying home if we're 100% confident in everyone's well-being.
Yeah, and it's not often if you said to a woman, I've got concerns for the well-being of your baby, that a woman would say, well, I'm actually not going to hospital. I'm sure that would happen occasionally, but, most of the time there's a trusting relationship where the woman is aware that you also want her to have a home birth and that you also don't have a preference for transfer. And so she trusts that if you're telling her she might need to go to hospital, she's like, well, if Mel's saying that or if Ashley's saying that, then
I really don't want to go. I really don't want to go. But
so then that's the kind of changes in fetal heart rate can be one thing, but we've got the tools for that and the skill to listen out for that. So the next thing that we have managed together, Ash, is shoulder dystocia.
Ooh.
Yes. And there was a whole episode on shoulder dystocia.
I mean, yeah, look, shoulder dystocias have a reputation for evoking a very strong fear response in a lot of healthcare providers. Because in terms of, are we going to preempt, there are signs that you have a shoulder dystocia evolving. The vast, vast majority of these are occurring in hospital with epidurals, with people lying on their back, normally with syntocin and running. And then when you add an instrumental birth, often the direction of the rotations with an instrumental birth actually basically creates a shoulder dystocia. So it is very different shoulder dystocias in the hospital to shoulder dystocias at home, because we know when we have a shoulder dystocia at home, the baby has well and truly got themselves in that position.
Yes, because one of the potential causes of shoulder dystocia is actually it's iatrogenic, so what we call medically induced. So we know that babies who are born through induction have a higher chance of shoulder dystocia. Babies whose head has been assisted out by forceps or vacuum have a higher risk of shoulder dystocia. If you're on the bed, your pelvis, the outlet actually changes shape, and so you could have a higher risk. And any kind of interruption from the birth clinician at that time to assist the head out could inadvertently wedge the shoulders. So like what Ashlee was saying is if you're at home, the women have done a lot of things that would eliminate the risk of there being an iatrogenic shoulder dystocia. So when it's happening, we're like, right, this was going to happen anyway. and this is can be preempted, but most of the time it's happening, and this is one of the faster. I wouldn't call it an emergency, though. I wouldn't call the shoulder dystocia an emergency.
It's just a skill that requires a skilled birth attendant who is being trained in it and knows how to manage it. And then you've also got all of the different schools of thought about what really constitutes the shoulder dystocia, because you'll hear a lot of debate.
And yeah, in the shoulder dystocia episode, we did sort of talk about that if the baby comes out with external maneuvers, was it really a shoulder dystocia?
Like if you had to put someone's leg up in what we call McRoberts, which is basically creating a deep squat, which, you know, for most of our shoulder dystocias, particularly if the women are in the bath, the first thing they do is they get out of the pool and the baby drops out. Well, that was just a positional change thing. I would really kind of call that a shoulder dystocia.
Well, and the woman herself, by her own means and capacity and own understanding of how her baby's feeling in her pelvis, might do some maneuvers and changes that change the positioning of the baby that allow it to come out. And so, yeah, I think if we're calling it shoulder dystocia, I think it's because you need to start acting and doing internal maneuvers. And so this is what, so it happens quickly. Well, you notice it quickly, but it's not necessarily an emergency unless you can't get the baby out, which they always come out. And we heard Cheryl say that yesterday.
It's just time sensitive. Like, you need to get the baby out within a certain period of time so that they're not compromised.
Yes. And so we go, okay, we're having a shoulder dystocia. That's okay. This is a midwifery skill to be able to manage shoulder dystocia. And shoulder dystocias are managed in hospital or at home because the tools that we use to manage shoulder dystocia are only our two hands. There's nothing fancy. And so whether or not those two hands are in hospital or at home, the strategies are similar. And
your most effective thing for a shoulder dystocia that does require internal maneuvers is actually the clinician. So it's actually not really about being at home at this point or in the hospital, but rather who is attending you that has the experience to do this. You are the midwife. It is a midwifery skill to manage a shoulder dystocia. And one day there isn't going to be a doctor that you just press a button and have someone come in and take over. And nothing makes you more confident with a shoulder dystocia than actually doing it and realizing that you are completely capable of managing that situation.
Yeah. And so although it's a complication, we also are midwives who have the skill to deal with this complication. And so then we did, didn't we?
Yeah.
We got
like big shoulder dystocias are thankfully very rare.
Yes. And so our strategy with the ones I'm thinking of was that we got the woman out of the pool. Mm-hmm. And if you heard the episode with Cheryl Sidery on Monday, the last episode, 79, she talked about the running start position for women. So, again, you're just changing the shape of the pelvis to see if we can dislodge the shoulders. And if that doesn't work, the woman's on hands and knees and you access the posterior space of her pelvis and go in to retrieve the posterior arm.
Which is one of the last mechanisms they actually teach in the hospital, but they have gotten to the point now with the helper mnemonic, instead of teaching people like to do it in order, they've kind of adapted it more to now, like you can do multiple of these sorts of things. And the fascinating thing about a true shoulder dystocia is there is so much space in that posterior area.
Yeah.
There is actually space there. You do not need to do an episiotomy for a shoulder dystocia. No. I find that just insane.
Yes. And as Cheryl said last week too, don't attempt the anterior space first.
Don't even go there. No, it's wedged. It's stuck. That's the whole point. And like in some of the breech courses, they've got that stuck drawer sort of thing. If you have a drawer that you're trying to open, like a utensil drawer, and one of your utensils is stuck up and you can't open it, you push it back in, you move what is blocking it, and then you come out. Do not pull on that baby trying to get them out. It's all about the mechanisms.
Yeah.
I feel like I'm like my university lecturers when I first at uni. It's all about the mechanisms.
Ashlee's getting very passionate about this, and rightly so. Do you know what, though? As home birth midwives, we have to be prepared for these things. Sometimes midwives in hospital, they don't necessarily have the urgency. They think, well, if there's a shoulder dystocia, there is always going to be a more senior midwife than me, or there's going to be a doctor present. We don't have that option. Like if there's a shoulder dystocia, it's me or Ashlee. That's it. And so I guess we're highly motivated to be skilled, maintain our skills, and maintain our confidence in the skill. And so, yeah, in the circumstances we've had at home, it's out of the pool. And also, once you've both agreed, yes, we are dealing with a shoulder dystocia, the one midwife manages the maneuvers to dislodge and get the baby out.
And
the other midwife is on the phone to the ambulance.
Yeah,
right.
100%. You're getting your assistance there, because when you have your true shoulder dystocia, we'll talk about another emergency, but you're also attempting, you're thinking that you're going to need to resuscitate this baby after you get them out. They will normally need a level of resuscitation.
And it's not always serious. They just are born needing some assistance. And so we don't know, is it going to need a lot? Also, what we don't know is how long is it going to take to get the baby out? And so the longer the baby's in, the more help it's likely to need. And so we don't want to wait for 6 or 7 minutes before we realize the baby needs help. We want to call an ambulance before there's an emergency, so that if there is one, we can get some help.
Like one of the ones I'm thinking of that we were at together, there were a few circumstances in this person's history that kind of did put us on the trajectory of thinking that a shoulder dystocia was possible. And Mel was the primary midwife. I arrived with head on view. So I think I ended up being at this person's house for like a whole grand total of like 1 hour. And it was like an interesting 1 hour. I could feel my heart rate going the whole entire time. But the first thing was everything, all the equipment was laid out, ready to go. And then as soon as we identified it was a shoulder dystocia, like Mel's phone was already sitting there ready. And we'd already like had the conversation with the dad. And it was like, you are going, like, this is what we are going to do.
Yeah. And in that circumstance, we don't always have the other parent
aware
calling
that one.
Yeah, they had that baby. Their previous baby she'd had a shoulder dystocia with, and they thought maybe this baby was big, but it wasn't. And so we talked about it, and we'd agreed that actually you and I would both be hands-on in that circumstance, and the dad was happy to call an ambulance, and that's what we did. We just kind of activated him, and one of us got the baby out, one of us got the resus gear just in case, and then we did resus that baby. But as we were on the phone to the ambulance, the baby's condition improved, and by the time the ambulance got there, the baby didn't require any further assistance. It was skin to skin with its mum.
But by the time that first guy walked in, and that was like 4 minutes after the birth, that was an insanely quick response time. I remember saying, because you had the speakerphone on, that we had spontaneous respirations, that the baby was now completely fine. And and the amazing thing was we actually get to do those resuscitations at home the way the advanced life support guidelines actually say, which is to keep your cord intact.
Yes.
And it makes such a difference.
Yeah, exactly. And so for one baby, we just did oxygen. For the other baby that we assisted, it did need cardiac compressions, but not much. And again, by the time the ambulance got there, the woman and the baby were on the couch. The baby was skin to skin with the woman, not needing any further attention. So although we were in a complicated circumstance that could have turned into a significant emergency, we managed the complication so it didn't become an emergency situation. So actually, both times we used the ambulance for transfer, not for actual clinical care.
And you transferred and got paediatrician reviews afterwards.
And that babe didn't spend any time in hospital after that, did it? So, yeah, but all of our circumstances have resulted in babies that were ultimately born well and had no long-term repercussions to their circumstance, didn't need to spend time in hospital, but we did transfer for pediatric review. And I remember transferring for the one of them and saying, and they said, oh, what have you come here for? And I said, well, we had a shoulder dystocia at home and I just want to have a pediatric check on the baby to make sure it is all well, like it appears all well to me, but I'm not a pediatrician. And the hospital's been amazing. They're like, wow, you did an amazing job. The baby's in great condition. We will check the baby over and, send you guys home. So I guess the equipment we used in that was, again, our own skill and tools of assessment, our hands, the strategy of getting...
You just need a bag and mask, resuscitation equipment in your hands.
We have an oxygen tank, so we can do that. And yes, obviously our hands and being able to listen to the heart rate so you know which level of resuscitation you need to actually do.
And I feel like, the shoulder dystocia really plays into the neonatal resuscitation because we've probably given a few puffs to our babies here and there, but I don't think we've had any neonatal resuscitations at home that haven't been after a shoulder dystocia.
No, very rarely. If you've had a well baby through the birth, it's very unlikely that you're going to suddenly be presented with a baby that needs resuscitation if everything's been well up to that point. Like shoulder dystocia seems to be one cause of needing to resuscitate a baby after birth. The only other time we did need to is there was that birth, the baby came out and the baby's colour made me feel like the head came out and I was like, ooh, that's not a good colour. And I said to the woman, can you hop out of the pool? Because I would really love to check that to basically have your baby not in the water. And as she got out and I assisted the baby out, I could see that there was a loop of cord coming down with the baby's hand that was white. And I thought, oh, that's strange. I wonder if there was cord compression there. That baby needed a little bit of assistance where there hadn't been a problem prior. But again, it was well after a little bit of midwifery attention.
And keeping in mind for everyone that this is very small numbers of births compared to the overall ones, we're definitely picking the worst sort of scenarios. It just made me think, I'm like, it makes it sound like we're always getting people out of the birth pool. No.
Well, no, but today...
It is about all of the things going on.
No, I mean, it was fine. But this is, today, that's right. I had the impression that, every baby has an emergency. We are specifically talking about the cases that we've had to engage our emergency midwifery skills.
And I don't kind of really go into the idea that, shoulder dystocias are because of like the particular shape or something like that of someone's pelvis. As Mel said, most of them are iatrogenic. That being said, I do have one client who has had her second and third baby with me, and all three of her babies have had shoulder dystocias. The second and third were fine. In fact, the second I didn't even touch, which is a kind of alluding to a little. So it got classified as a shoulder dystocia because as that baby was spontaneously born, it fractured its own clavicle, which basically means the body did something to reduce the space for it to be born, and that the baby recovered from it completely fine. But it was a little bit like I was shocked to find that out afterwards because I didn't touch that baby. So, but that did influence our choice of birth location going into planning her third baby, when you're talking about someone who's had 2 for 2. And I mean, in the end, the shoulder dystocia she had with the third was, again, pretty minor. Yeah, when you're kind of talking about someone who's had 3 for 3, the conversation shifts a bit there.
Yeah. And that also speaks to the fact that, what we do for our clients during their antenatal care is to try and understand their particular circumstances so that we can anticipate or prepare for potential complications before they even happen.
Yeah.
Yeah, exactly. And so, if somebody has had 3 babies and 3 shoulder dystocias, then the conversation about what do you want to do if there's another shoulder dystocia at home, or what do you want to do, or where do you want to have your baby, considering there's a pretty good chance you're going to have another shoulder dystocia, that becomes a big conversation. Whereas we wouldn't normally discuss the ins and outs of shoulder dystocia with all of our clients, but, with these particular ones, you would. All right. So that's, so the fetal distress one can be a quick or slow burn complication. Shoulder dystocia, again, that's probably the one that sneaks up on you the most, where you go, oh, we're having a shoulder dystocia, and you have to act. Then obviously the sequelae of having to do a resus. So then if we move on to the birth of the placenta, and this is something that panics people as well, is shoulder dystocia seems to be very fear-inducing for clinicians. And the other one is postpartum hemorrhage. So there's after you have your baby, there is a potential opportunity to have a large bleed. So, and this is where a lot of people are deterred from choosing home birth. And when I have clients or potential clients, I always allow them to come and interview me before they hire me. And it's usually the partners who say, what are you going to do if she bleeds at home? So I thought we'd run through there's a few things, what the hospital would do, but also what we would do. And in our kit, we carry a lot of medicines. We carry syntocinon, which if you're in America or somewhere else, it's Pitocin, but artificial oxytocin. Sintometrin, which is a combination medication. We carry misoprostol, which is administered rectally. We carry RV fluids, tranexamic acid. Sorry?
That's my favourite.
That's your favourite? We carry some herbal stuff too, some no bleed formula, which we wouldn't give as a first line treatment, just out there if you're looking for ways to.
I was about to say before when you say what we do that's different to the hospital, and I'm like, I know that there's always the hospital rumours that we, when people bleed, they think at home that we're just, sprinkle herbs out and, send our prayers, and it's a little bit more sophisticated than that, but we do have a few natural sort of things. Like putting the breast. Oh my goodness. First thing.
Put the baby on the breast because that induces oxytocin contractions. We also have aromatherapy, clary sage, which also induces contractions. Some people say, and again, I'm not endorsing this, but if the placenta's already out, I have heard midwives say you can pop a piece of that in the woman's cheek, but I've never done that before. So at hospital, if somebody starts to bleed, then they have all those medications as well. The same medications are what we have.
And it's also probably been caused by interference.
Well, see, this is the other thing,
isn't it? Like,
yeah.
In the hospital, we know that the reasons people bleed are things like really long labours that maybe have been a bit obstructed or something like that have often been augmented with syntocinon. So drugs, like those sorts of ones there. You're going to have your episiotomies, say people that's a risk factor for bleeding. Then you've got your instrumental births. So by the time you add together induction or augmentation with an instrumental birth and episiotomy, like we're anticipating that. But also in those situations, you've already flooded that woman's body with those oxytocin drugs. So those oxytocin drugs aren't so effective anymore. Whereas in home birth, we can use any of the things because they all work so well.
Yes. Well, that's been my experience, is that because this is the difference, is with a physiological birth, if the woman's bleeding, you know that the only thing that no interventions have contributed to that. And some people would say, oh, well, actually maybe the midwife being there was enough to cause the woman to bleed. Like I know there are some women who choose free birth who would say that actually the presence of a midwife can increase the risk of postpartum bleeding. I don't know if that's true or not because there's no way to know that information, but from what we know with our data that we've got. But the chances that something that's happened at home has caused the bleed is less likely than at hospital. So we know that she hasn't been given any medications. And so when we give our first line treatment, the syntocinon injection, most of the time that's enough. That works. We don't have to do a single other thing. And the placenta comes out and the bleeding stops. And there's been a handful of times where we've had to progress to the next line of treatment that we use, and that's sintometrin and IV fluids. Very occasionally, but most of the time, all of our medications that we use for bleeding go out of date and we need to reorder them again to have them up to date in our kit. So it doesn't happen very often. And my general rule is if I've had to give symptometrin and put up IV fluids, then it's time to call an ambulance.
Yeah, you're transferring at least for observation because even though you might manage it completely fine, you do need to be able to walk away from a home birth knowing that someone is going to, be stable and they're not going to start bleeding afterwards.
Well, you do need to ask yourself, I've just given her a medicine to stop her from bleeding. What's going to happen when the effects of the medicine wear off and I'm not here anymore? So yeah, I guess we do carry all the same medication that you would be offered in hospital. The difference is that we administer it staggered. So we would give the syntocinon, and then if that works, we wouldn't do anything else. If it doesn't work, we move on to the next thing and the next thing and the next thing. Whereas from what I've noticed for hospital management, the use of all of the tools cascades pretty quickly. So they'll go from syntocinon and then move on to almost straight to tranexamic acid these days and IV fluids.
Acid is now, they keep changing it, but I was in the hospital last week and they've actually gone to sometimes the second 10 units, which is great because that's actually something that we would do at home, but they're actually moving to tranexamic acid. Tranexamic acid is great because it will basically stop bleeding wherever it's coming from for around 30 to 45 minutes. So you can kind of treat the cause of the bleeding and it stops them from bleeding while you're figuring that out. Mm-hmm. But then you also need to be really sure about what your cause is.
And Ashlee is amazing at managing bleeding emergencies because she worked for a long time as an emergency nurse in A&E, accident and emergency. So, yeah, in terms of the same medication, we've got it and can use it. And we've had an occasion where we had a client who had bled for her other previous births. And this time she looked us dead in the eye and said, if I bleed this time, I'm not transferring. And we were like, oh, okay, we need to be uber prepared. And we were. And she got the same medications that we gave her last time and IV fluids. And everything stopped. And she felt pretty well and didn't need to transfer.
Yeah, I mean, essentially with bleeding, if you've got all of those medications, we are doing the same thing as what they would do in the hospital for bleeding. The only thing that we can't do is go to theatres. And if you're bleeding in a way that needs you to go to theatres, no one's really thinking, do we stay at home? Do we go in? We're going.
No.
If someone's bleeding like that, you're giving tranexamic acid, which is going to buy you the time to transfer in.
Yeah, and we watch very closely to check the woman's observations. So we're checking her pulse and her blood pressure and observing her and how she's feeling. And if she's symptomatic, because that's the other thing, is if we've treated the postpartum hemorrhage but she's still symptomatic and she's not actually visually losing blood, then we're still transferring because we still can't tick the box of is the woman well? No, she's not well.
Go to the bathroom
and the other thing we do is put in an indwelling catheter in her bladder to reduce the amount of urine that's in their bladder to make sure that that's not interrupting the contraction of the uterus.
So I think the whole time I've been with you, that we've been working together, we've done 2 transfers for PPH and 1 retained placenta.
Yeah, and that's in 4 years.
Yeah.
So, yeah, in 4 years, there's been 3 circumstances where we've needed to escalate care for a postpartum hemorrhage. And we've probably done nearly, I think I counted the other day, 160 births.
Yeah.
A lot. So considering that that's been the number of transfers for bleeding.
Rates of anywhere from 5 to 15% for PPH of over a litre in the hospital. Obviously, that is complicated scenarios that we aren't having happening at home, so you would expect our postpartum hemorrhage rates to be lower than in the hospital.
Yeah. So that's how we manage a bleed at home. That's our emergency equipment. We've got oxygen, resuscitation equipment, suction, all the medications we need for postpartum hemorrhage, IV fluids. We can do catheterization if we need to. We can cannulate. We can do stitches if the bleeding happens to be coming from a tear, which I don't think we've ever had to repair a bleeding tear at home. One time, okay. Yeah. Actually, can remember the one time.
Easy.
Oh, yes, we did that. That's right, the one time. Yeah.
And then the other emergency that you mentioned earlier was cord prolapse, which I don't think you've ever had one.
There was only that one where the baby was coming and I noticed the cord was compressed. I wouldn't call it a prolapse, but it was definitely white and empty, and I thought that should be more full and excited than it was. And the baby was not in good condition when it was born, but I think that was more cord compression than prolapse.
Cord prolapse, I have seen them in my hospital context. I have seen it transferred one 10 years ago that was well managed by the midwife. Obviously, in that situation, the delay in getting into hospital isn't ideal. I do, because this is me to a T and I'm prepared for all situations. I do carry an ampule of a drug called terbutaline, which actually stops contractions. So if you had a cord presenting in front of a baby's head, which probably won't happen if you don't break waters, and we don't break waters at home, so you pretty much make it a non-existent thing. But you push the baby's head up off the cord to stop any compression, and you can put a catheter in. So we've already got the catheterization equipment for the PPH, but you can put like a clamp on it, and you can actually drain fluid into the bladder. So the opposite to like making us telling people to pee lots in labor, is you actually fill the bladder up with fluid. So this would be like very much if you had a cord prolapse in a home situation and there was a period of time that it took you to get into hospital. So you'd give them the terbutaline, which is a drug that's going to stop contractions. So you're going to fill their bladder up with fluid. So you push that baby's head up. You're going to have a midwife, unfortunately, with their hand inside your vagina for the whole entire journey in there, that's going to be pushing that baby up, and you're going to be communicating with the hospital. So
and the woman would be head down, bum up. So you want to create a circumstance where the baby's not putting pressure down onto its cord, and that's the reason that the midwife is holding the baby's head off the cord in order to stop it from getting compressed. And at that time, you can also, if you're in an ideal position, feel the baby's heart rate through the cord to know if all of the strategies are being effective. So if you've got a cord prolapse and the woman is head down, bum up, and you're keeping the head off the cord and the bladder's full, which is hopefully preventing the baby from moving down further into the pelvis, and hopefully she stopped having contractions because the medication's taken effect. If you can feel in the cord that the baby's well, then you can keep reassuring the woman and we can calmly transfer to hospital. I mean, it is an emergency. Like that absolutely have to go.
Emergency, yeah.
It's an actual emergency. And, but certainly we've got the skill. It's about identifying the emergency, having the equipment to manage it, having a quick transfer plan. So we also book all of our clients into their local hospital. So if we need to go, then there's no delay in accessing the woman's information. And, we just go straight in.
And breach is not an emergency. It's a variation.
Breach is not an emergency. It happens sometimes. They catch us by surprise very occasionally. So we've got the skill if we need it. It's not an emergency. It's a variation. So if you are in labour and your baby's presenting bum first, and that wasn't anticipated, then we go, okay, we are doing a breech birth. On those occasions where that wasn't intended, I do, again, err on the side of caution. We know that about 30% of breech babies are going to need a little bit of a handout to get out. And sometimes they're born a little bit surprised.
They just need their first APGAR at 2 minutes, not 1 minute.
Sure. But we may also anticipate calling an ambulance for that scenario.
Yeah, and I think it depends with breech how skilled your care providers and how confident they feel with that. And how far before the baby is born that you've found that out. Now, in home births, we don't really do vaginal exams. So sometimes the first idea that we've got is, especially if they're underwater, is that a head? Oh,
Is it
bottom.
okay. That's right. That's right. But yeah, again, that's not an emergency. That just requires midwifery skill. So there are sometimes complications that happen that require us to use our skills, and we've got the equipment for that. Then there are emergencies, and basically we are anticipating that we need to manage that emergency until the ambulance arrives. So we've got the equipment we need to do that. And then we're escalating care into the hospital. Yeah, I think those are the...
Sure. What we are there for is managing medical complications and emergencies if they should arise.
Yeah, and then most of the births happen just normally, and we're just there to tell the woman, yep, that's normal.
That's normal, that's normal, that's normal.
Yeah, that's right. Well, I hope everybody has had their questions answered about, well, firstly, can midwives manage emergencies at home? Yes, we can. And also that you've understood what equipment we carry and the types of emergencies and complications that we can manage. That has been this week's episode of The Great Birth Rebellion, and I will see you again in the next episode. Thanks, Ash.
Thanks for having me.
Thanks for coming.